everyone. It's my honor to be here and share this case, fever with hemophagocytic syndrome secondary to EB virus and Hantavirus infection with you. My name is Zhang Ruyi, and I am from the Department of Medical Lab, Nanfang Hospital. Let's review this case. On May 11th, a 41-year-old man was hospitalized for fever up to 38 degrees at our hospital. No history of chronic diseases or relevant diseases were reported for him. The physical examinations and the lab tests were as follows. According to this, he was diagnosed as multiple organ failure, shock, and coagulation dysfunction. The blood cells analysis showed that the PLT amount was decreased, and the SWDF figure showed there was a group of reaction lymphocytes here. So we do the blood smear. And the results show that the amount of atypical lymphocytes were greatly increased. We contacted with the physicians that the patient might be infectious mononucleosis induced by virus infection. IM, infectious mononucleosis, is characterized by fever, pharyngitis, swollen lymph nodes, hepatosplenomegaly. The most common cause of it is EB virus infection. If not treated properly, it will induce HLH. HLH means hemophagocytic syndrome or hemophagocytic lymphohistiocytosis. These are the characteristics for him. And there are 8 diagnostic criteria here. Among them, hemophagocytic cells in the tissue may be the most important one. So we contact with the physicians in charge to do more tests. The results show that the EB DNA load was increased, obviously. And the bone marrow smear showed that the hemophagocytic cells were found and atypical lymphocytes were greatly increased. According to this, the patient was diagnosed as HLH induced by EB virus infection. So antiviral agents was added. However, on day 3, the patient was still in critical condition. The blood routine showed that the RBC and PLT amounts was decreased, and the liver function and the coagulation function were not improved. So we communicated with the physician that more examinations should be done to exclude other original cause. As the patient has bleeding spots on the chest and a history of exposure to worms, so we suggested that he should be tested the Hantavirus infection. The results show that the serological antibodies of Hantavirus were negative on day 4, but it turned to be positive on day 10. And the blood NGS reports show that the sole Hantavirus sequence number were 4. So, until then, the patient was diagnosed as SEOV infection combined with EB virus infection. There are 2 types of clinical manifestations of Hantavirus infection, HFRS and HPS. The patient went to our hospital with fever, high risk of bleeding, hypotension, and his urea protein was positive and the GFR was decreased, obviously, which were in line with the symptoms of HFRS. And the results of X-ray and the CT scan of the chest were in line with the criteria of HPS. So the patient was diagnosed as HFRS combined with HPS induced by SEOV. However, it was hard to maintain the respiratory function and the circulation function of the patient. He received ECMO, and further etiological tests of BALF demonstrated that the patient was combined with Aspergillus flavus infection. The CT scan of the chest also demonstrated that the prognosis of the patient was poor. So we continue to contact with the physicians to focus on the immune function of the patient. The analysis of T lymphocyte subsets showed that the ratio of CD4 positive T lymphocytes decreased, which confirmed the patient was under severe immunosuppressive states. As a result, thymosin was added. Although we tried our best to save the patient's life, he died finally because of respiratory and circulation dysfunction. In this case, we continued to contact with the physicians in clinic. When we found abnormal blood lutein and abnormal lymphocytes in the smear, we suggested to confirm if the patient had IM induced by EB virus. And when all the supportive therapies were given to the patient, but he was still in critical condition, more examinations were suggested to do and to exclude other original cause. When the prognosis of the patient was poor, further examinations like immune function and etiological tests were suggested. There are still some doubts in this case. Firstly, which induced HLH, EB or SEOV? Maybe the infection of EB virus-induced IM and SEOV infection exacerbated hemophagocytic syndrome. Secondly, why the results of serological tests of SEOV were inconsistent? The literature showed that serological assays are not specific to SEOV, especially when the immune functions of the patient is abnormal. Lastly, why HFRS combined with HPS in this case? Maybe the infection of EB virus combined with SEOV exacerbated systemic inflammatory response, which leading to multiple organ failure and critical situation. That's all for my sharing. Thanks for your listening.